Welcome to today's webinar, Prohibiting Discrimination under the Affordable Care Act, State Roles and Responsibilities. I'm Trish Riley with the National Academy for State Health Policy, and I'll be your moderator today. The issues before us are complicated, and we have a wonderful group of experts to walk us through them. Before we get started, I'd like to take just a minute to thank our funder, Pharma, for their support in making this webinar possible, and I'd very much like to thank our partners at Georgetown Health Policy Institute. They've been just invaluable in helping shape today's event. Let me just go over a few housekeeping items as we proceed. This is a web-based interaction, and phone lines support the webinar. You should be able to listen to the webinar through your computers, but a phone line is also available and listed on this slide. These lines will be muted for the duration of the webinar. At any point, though, throughout the conversation, you can ask a question. Just type it into the chat box located at the bottom left of your screen, and we will be responding to those questions at the conclusion of the presentations. Importantly, the slides and recording for the webinar will be posted on the NASHP website in the next few days, so they will be available in just a bit. Let me take a minute to quickly introduce each of our speakers and give you just the highlights of their bios. They are posted at the end of this webinar, and I want to get right into the meat of our discussion. We'll first hear from David Cassano. David is a research professor at the Center on Health Insurance Reforms within the Georgetown University Health Policy Institute. He's also a health policy group leader at the MITRE Corporation. He previously worked at CSIO. Wayne Turner is a staff attorney at the National Health Law Program, NHELP. Wayne prepared the HIV discrimination complaint that was filed by NHELP and the AIDS Institute with the HHS Office of Civil Rights regarding HIV/AIDS medications by 4 Florida insurers. Next, we'll hear from Lisa Campbell. Lisa is a principal at the Groom Law Group. She's the former Director of Compliance and Enforcement Division for the Oversight Group at CSIO and Group Director of Consumer Support there. So we definitely have state and federal people here. Tammy Killian is principal in the Health and Welfare Group at Groom Law. Her practice includes counseling large employers on the establishment and operation of their health care and other welfare plans. She previously worked at the U.S. Department of Labor. Johanna Fabian Marks is the Director of Life, Accident, and Health Product Regulation in the Pennsylvania Insurance Department. She, too, previously worked at CSIO, where she focused on market rules, rate review, and medical loss ratio provisions. And last but not least, Mila Kaufman. Mila is the Executive Director of the D.C. Health Benefit Exchange Authority. She's previously the Superintendent of Insurance in the state of Maine and has regulatory experience as well within the Department of Labor. So while that's short shrift for these great presenters, their full bios are available to you. Let me kick off today's discussion, and again, the slides will be posted on NASHP's website later, and you can ask questions at any point during the conversation. But let's begin and start with a frame-up from David Cassano, who will walk us through what are the anti-discrimination requirements of the ACA. David?
Thanks, Trish. Today I will be providing a brief overview of the non-discrimination protections under the Affordable Care Act, and then our esteemed panelists will share their on-the-ground perspective with implementation and compliance. Next slide, please. So under the Affordable Care Act, insurers in the individual and small group markets are required to cover essential health benefits. In covering these benefits, they are prohibited from discriminating against consumers based on age, expected length of life, present or predicted disability, degree of medical dependency, quality of life, any health condition, race, color, national origin, sex, gender identity, or sexual orientation. And these EHB non-discrimination protections apply to all insurers offering coverage in the individual and small group markets. Next slide, please. It's important to note that states generally have primary enforcement authority over these EHB non-discrimination protections. However, if a state fails to enforce them, the federal government does have the ability to assume that authority. Next slide. The Affordable Care Act also sets forth specific non-discrimination provisions applicable to qualified health plans participating in the federal and state marketplaces and prohibits them from employing marketing practices that would discourage enrollment of individuals with significant health needs. CMS assesses compliance with these requirements through QHP attestations and monitoring and compliance reviews. CMS also performs an outlier analysis that compares QHP benefit packages with comparable co-payment and co-insurance structures to identify cost-sharing outliers for specific benefits related to chronic and high-cost medical conditions. For the 2017 plan year, CMS will focus on bipolar disorder, diabetes, HIV, rheumatoid arthritis, and schizophrenia. Next slide, please. Finally, Section 1557 of the Affordable Care Act is a broad non-discrimination provision that applies to any health program or activity which is receiving federal financial assistance or that is administered by an executive agency or any entity established under Title I of the Affordable Care Act. For example, Section 1557 applies to marketplaces and qualified health plans. Section 1557 prohibits discrimination on the ground of race, color, national origin, sex, age, or disability, and HHS Office of Civil Rights has jurisdiction and enforcement authority. Next slide. The Office of Civil Rights has issued a proposed rule to implement Section 1557, which prohibits gender identity discrimination as a form of sex discrimination, enhances language assistance for people with limited English proficiency, and requires effective communication for individuals with disabilities. This concludes my overview of the non-discrimination provisions, and I turn it back over to Trish, so thank you.
David, thanks for a great overview, very clear. And let's begin our drill down with Wayne Turner from NHealth, who will address the question, what concerns and challenges have essential health benefit requirements imposed for consumers and consumer groups?
Well, thanks so much. Yes, one of the main issues, if we can go to the next slide, please, that David identified is what the nature of the protections under non-discrimination really depends upon what kind of health plan you have. Of course, the market reforms applied very broadly. The essential health benefits, or EHB protections, talk about protecting people with, quote, health conditions, whereas in the QHP world, we see non-discrimination addressing persons with, quote, significant health needs. This, of course, is different from Section 1557, which covers certain protected classes. So really drilling into the nature of these protections and how they interact with each other, providing an overall framework of non-discrimination is one of the big questions confronting consumers. But let's drill down in the next slide, please, on Section 1557, which is really the cornerstone of the non-discrimination provisions of the Affordable Care Act. It prohibits discrimination based upon race, ethnicity, age, sex, or disability. It's actually been the law since the Affordable Care Act was first enacted in 2010, although we are all waiting with bated breath for the final regulations to be issued by the Department of Health and Human Services. One important thing to note about Section 1557 is that it incorporates the definition of disability from the Americans with Disabilities Amendment Act of 2008. It's a very broad definition that discusses major life impairments, or impairments based upon major life activities and major bodily functions. And so with this very broad definition, it's difficult to imagine someone with, quote, a significant health need who wouldn't meet this definition of disability. And of course, persons with chronic conditions would also, in our view, meet this definition. But this is certainly an area that advocates ask for greater clarity from HHS in comments on the proposed rulemaking. One of the things that we were really excited to see in the final rule, in the proposed rule that HHS released on 1557 was an express prohibition on discriminatory plan benefit design and marketing. And so this has been an open question that was really forming the basis of a complaint that NHealth filed back in 2014. So if we can go to the next slide, please. Back in 2014, we were approached by the AIDS Institute, which is a Florida-based HIV/AIDS advocacy organization, and they conducted a very in-depth analysis of all of the drug formularies of the silver plans in Florida. so some 24 plans and over 20 HIV/AIDS medications. And they found a number of problems, including formularies that didn't cover some of the most commonly prescribed HIV/AIDS medications, including the single tablet therapy, which is pretty much the standard of care in HIV treatment. We decided not to pursue that in our for a complaint, because these plans all met the standard for essential health benefits of one drug per class and category. And so we decided to focus our complaint on the second issue, which was on cost sharing. Cost sharing was all over the map, but there were 4 plans in particular that placed all HIV/AIDS medications in the highest cost sharing tiers, including generics. And so we prepared and filed our complaint with the HHS Office for Civil Rights, really to pose the question that 1557 protects against discriminatory plan benefit design, that we can get into the content of the plans through 1557, rather than 1557 simply applying to how the plans are sold and how the services are delivered. Now, this is important because we want to see national standards and national monitoring of federal non-discrimination protections. We could easily imagine a situation in which, say, a prescription drug formulary offered by a plan would be found discriminatory in one state, but then another state says, no, that's fine, it doesn't discriminate. And so that's why we went the OCR route. Now, of course, the Office for Civil Rights at HHS works with the state insurance commissioners, and we were quite fortunate in the state of Florida that we had a commissioner who had a strong sense of the public interest, and so the commissioner took a number of regulatory actions based both on state law and on EHB requirements, but did not specifically mention 1557 in his decision. We did see some favorable language from CSIO, the Center for Consumer Information Insurance Oversight. They had some terrific language in the letters to issuers and in the preamble to the benefit and payment parameters rule that talks about the discriminatory. It could be discriminatory if a plan placed all medications in the highest cost-sharing tiers. They also talked about plans that failed to provide single tablet therapy as possibly discriminatory. So we were really happy to see that language in that sub-regulatory guidance. However, we have not heard directly yet from OCR with a final decision. Remember, our complaint was on the plan benefit design for 2014, and so 2 years have passed since then. But if we can go to the next slide, please, we can see that we have seen some federal, some really positive language in the budget proposal for OCR. This is in the President's budget plan, and of course, OCR is anticipating a big uptick in complaints, and they acknowledge that these are new issues regarding how to evaluate the plan benefit design, and they recognize both this discriminatory drug tiering structures, the adverse tiering, as one of the issues that they expect to be focusing on. They're also going to be looking at coming up with ways to evaluate plans. So next slide, please. One of the challenges is that there is no bright line on deciding whether a plan benefit design is discriminatory or not. It does take a fact-based analysis, very much what the AIDS Institute did, but we can look to the letters to issuers and the benefit and payment parameters rule for a suggested framework. So if we can go to the next slide, please. I mean, one of those is what was mentioned earlier, an outlier analysis. This is comparing plans and looking for outliers and cost-sharing structures and tiering structures, just the adequacy of the formularies. There's limitations to an outlier analysis because it assumes that you have some good plans to compare the bad plans to. One of the big fears, though, is that if we don't address discriminatory plan benefit design, then there's going to be a race to the bottom, and that we'll have all bad plans. SCIO recognizes very much that just because a plan benefit design looks like others doesn't mean that it's non-discriminatory. Next slide, please. But there's another framework to look at, and that is how the formularies and the services and the cost sharing compares with treatment guidelines and standards of care. So this is articulated in the 2017 letter to issuers. And it provides an important opportunity to really look at plans and plan benefits and how they compare. One caveat to make note of is a comment that was in the preamble for the 1557 regulation that just because a plan doesn't cover a particular benefit doesn't mean that that's necessarily discriminatory, that we're looking at coverage policy here. And so in framing a 1557 complaint, it's not just I want this particular drug, but it has to address a broader plan benefit design scheme. So if we can look at the next slide, please. These are some of the things to think about for framing a 1557 complaint. Certainly we'll know more when the final rule is issued on terms of what are the covered entities under 1557, and we'll hear more about that. A complainant needs to address under 1557 whether he or she is part of a protected class and describe the discriminatory activity. One thing to keep in mind is what process should we use? Plans have an internal grievance process, but of course state insurance commissioners present an opportunity to complain and to rectify situations. And then of course there's OCR, the Office for Civil Rights. Just one final cautionary note. I mean, in 1557 there is a federal cause of action, but please don't rush to federal court. We want HHS to speak about the contours of non-discrimination in the ACA, and just be very careful about getting a bad decision out there that really limits the opportunities for people in the future to file complaints. And so with that, we'll turn over to the next speaker.
Wayne,
Great, thanks.
Go ahead, Lisa and Tammy.
Great, thanks so much. First of all, good afternoon, everyone. It's a pleasure to be here this afternoon. Tammy and I will cover the issuer role in the non-discrimination requirements, including some of the challenges that issuers are facing in meeting these requirements. So next slide. So the issuer role really is to follow all of the rules and regulations relating to non-discrimination. And while that may sound simple, what is involved in meeting all of these requirements is much more complex. And what this slide shows you are 3 different ways in which this can be complicated for carriers. First, issuers need to coordinate and comply with multiple layers of regulation. Early in the presentation, David and Wayne reviewed some of the non-discrimination requirements that apply to health insurance issuers. And while they did review most of them, there are other ones as well. They talked about the exchange-specific rules for issuers offering coverage on the marketplaces, the essential health benefit rules that apply market-wide, both on and off the exchange. Wayne talked about the market reform non-discrimination rules that apply market-wide. We have the ACA 1557 rule. There's also the EEOC non-discrimination rules for issuers offering group coverage, and then state-specific rules that can include certain state benefit mandates. So that's really the first point that we wanted to make with regards to multiple kind of layers of regulation and what makes this complex. Second, issuers are regulated under a complex regulatory enforcement framework, particularly as it relates to the non-discrimination rules. So as a result, issuers have multiple regulators at both the state and federal level. So for the exchange non-discrimination rules, issuers are regulated by CMS if they're offering coverage on the marketplace, or the state exchange if they're in a state-based marketplace, or they can actually be regulated by both if it is a partnership state. For the EHB rules, I think Wayne or David touched on this, states do have primary enforcement authority, but issuers can be subject to dual regulation if it's a direct enforcement state. So that's also another area where they have to kind of answer to 2 regulators. For 1557, issuers are regulated by OCR. For EEOC, the EEOC will enforce those rules. And then for the state-specific non-discrimination rules, the states will be enforcing. So as a result, issuers can have up to 5 regulatory entities enforcing similar requirements differently, and I think that kind of gets to some of the challenges. And the last point is really the non-discrimination requirements and guidance. It can either be very specific. For example, mentioned earlier was the transgender requirement, so carriers are prohibited from having exclusions for the treatment of gender dysphoria. And then also meaningful access requirements. The regulations that have come out have been very specific in what's required. But also the rules can be broad. And, for the one example would be benefit designs should not discourage enrollment by high-cost enrollees. So as you can imagine, the broad requirements can be difficult to interpret. And those benefit designs that issuers have can be found to be discriminatory, even if that wasn't the intent behind the benefit design. Next slide, please. So what this slide shows you is a little bit of an overlay of what I just talked about, but really getting to the specific challenges that issuers face in complying with all of these non-discrimination requirements. So the first one is really, you have some requirements depending on rulemaking, or if a court were to come out with an action, you could have requirements becoming effective mid-plan year. So that has its own challenges, with the state form filing requirements, getting any changes approved, or having benefit designs, in your plan that haven't gone through that process. That also has an impact on rates. Rates are set well in advance of, any kind of new requirements may take effect. So you could have carriers that are offering benefits that they really didn't incorporate that into their rates, and then that could trigger significant changes for the following year. And then also there is the guaranteed renewability requirement that prohibits changes to benefit designs mid-year. And so it's a challenge for issuers to come into kind of compliance with new requirements that become effective outside of the normal cycle. We already talked a little bit about the broad requirements, and I think Wayne touched on this as well. I mean, it is difficult for issuers to know how the rules will be interpreted and what specific benefit designs are or are not permissible. And, in some cases, there really isn't enough guidance about, what is considered discriminatory. So multiple regulators can have varying interpretations. For example, while a plan may meet the non-discrimination standards under the state review and for the QHP certification review, OCR could still find an issuer to violate the non-discrimination requirements, and this is a challenge. So also,
right,
issuers.
I was just going to note that I think the biggest challenge here for issuers, if it's not entirely clear from our slide, really is that we don't all agree on what may be discriminatory, in the sense that one regulator may find certain benefits to be required and another regulator may not. And I think, Wayne, you mentioned that early on as well. So when we add courts into this mix, we have the possibility of certain benefits being required in certain states to be non-discriminatory, and other benefits in other states which maybe not. And again, so adding, we already have that challenge with multiple regulators and multiple entities trying to interpret the broad requirements, but then when you add sort of a court overlay on top of that, that means that issuers are looking to a lot of different places for guidance in what is permitted and what is not, in addition to sort of what they're trying to do on their own, trying to design the benefits they believe are sort of most effective and most cost efficient and most attractive to their members.
Yeah, thank you, Tammy. And that's also consistent with the bullet. The second to the last bullet on this slide is the regulatory agency's interpretation. So whether it's the information that is coming out of a result of investigations or through a court, it really is, in a sense, after the fact, and it's difficult for carriers to know what the rules are, what the parameters are, before they get those kind of agency or the agency interpretations or investigations or potentially court decisions. The last bullet on this slide that's a challenge is the varying standards for meaningful access. So QHP certification requirements have their own set of meaningful access standards for taglines, and HHS OCR, for example, has a different standard. So it would be helpful if federal agencies work together to have one standard that issuers could comply with, and that was determined to be non-discriminatory and providing the appropriate information to consumers. Next slide, please. So where is additional guidance needed? I think you'll hear from all of the presenters that it would be helpful to have more guidance on non-discrimination for all the reasons we've talked about. We are now starting to see litigation around the ACA 1557 provisions, And the question is how should issuers, reconcile any conflicts that may come up with the courts and agency requirements. The second bullet is really getting to the 1557 proposed rule. The ACA 1557 proposed rule provides that the non-discrimination requirements that apply to issuers would also apply to that issuer's activities as a third-party administrator. The concern here is that issuers do not necessarily control the benefit design of the employer plan sponsors, and this is particularly an issue for the large group self-funded plans that aren't subject to all of the essential health benefit requirements under the ACA, but now will be kind of brought in under the realm of 1557, indirectly through their TPA. And last, I think one thought is are there any safe harbors or ways to demonstrate compliance? This gets to the point of, issuers go through the state review for their policy forms and approval. They also go through the QHP certification, which I believe Wayne or David mentioned. They really have created, more in-depth and comprehensive testing for non-discrimination for QHP. So the issuer goes through those requirements and demonstrates compliance with the non-discrimination rules. What would be helpful is allowing that approval from the state and the QHP certification to be a safe harbor that they are demonstrating compliance with the non-discrimination, so that it would save them from really having these multiple avenues of regulatory enforcement, because that can be challenging from a compliance standpoint. Tammy, I don't know if you wanted anything to add. I'm finished.
Nope, that's it.
Thank you.
And I'll turn it over to the next speaker.
Let me just remind folks, thank you both, that was terrific. Let me just remind people, if you have questions, please type them in the chat room. We're getting some, and we will hold them for the conclusion and make sure we get to as many as we can. And with that, let me turn now to the state perspective, the regulatory perspective, and Joanna Fabian Marks from the Pennsylvania Department of Insurance and Mila Kaufman from DC HealthLink.
Hi, this is Johanna, and we can move on to the next slide. So I'm with the Pennsylvania Insurance Department, and I'm glad to have the opportunity to talk with you today. Part of my job here is to manage health insurance form and rate review at the department. So I'm going to briefly describe the various types of non-discrimination oversight activities that we perform, and I think these are pretty typical of many insurance departments. So starting off with things where we have the definite lead. As a state, our first pass at reviewing for potentially discriminatory plan features occurs when we review plans coverage forms. So forms like the application for coverage or the certificate of coverage. We check for compliance with state and federal law during that review, and that includes checking that the forms don't contain discriminatory language. So that review takes place on the front end before plans are sold. If during the year we become concerned about a particular topic, we can issue a data call to our insurers and request more information. For example, last year we asked insurers in our market to send us information on how they were ensuring that their formularies complied with non-discrimination requirements. And we also have the authority to conduct market conduct exams on the back end. So in market conduct exams, we evaluate insurers' compliance with applicable law. And in the course of an exam, we will generally review both the insurer's policies and procedures and dive into claims and other data to get a deeper look at issues. Of course, we are also collaborating with the federal government these days. Pennsylvania has a federally facilitated marketplace, or an FFM, and we work with the federal government to review qualified health plans, QHPs. Different states pursue different levels of involvement in review for compliance with QHP standards. Here in Pennsylvania, we're transitioning this year to take a more hands-on approach for QHP reviews, and I think that's going to strengthen our review of QHPs and non-QHPs. In prior years in Pennsylvania, the feds took the lead on reviewing QHP templates, for example. So if they identified a potential non-discrimination from their template reviews, they'd notify us and the insurer, ask the insurer to submit a justification or change their plan design, and then we, the department, would review and sign off on the justification or change. So that was how things worked in previous years, and this year we're getting more involved. The feds also conduct QHP compliance reviews, which are reviews during the plan year to check for compliance with QHP standards. They will notify us in advance of such review, and to the extent they select a PA insurer for review, we're interested in the future in working with CMS to incorporate that into our own market conduct exams. And that's because we take our enforcement authority very seriously, and it's important to us to minimize any potentially duplicative reviews. We think that's more efficient for our insurers, and as the primary regulator, it's important to us that we have that firsthand knowledge of what's happening in the market. And lastly, but very importantly, we work with consumers, consumer groups, and our sister state agencies to discuss concerns and solicit complaints. Investigating consumer complaints is another one of our key ways to discover and address issues, and we have a great consumer services division that intakes and investigates complaints. To be honest, we haven't really gotten much in the way of complaints related to non-discrimination in our state to date, but I think this is one of the areas where outreach and education is key so that consumers know what their rights are and know that we're here to help. Our Commissioner Miller, established a consumer liaison position at the department last year, so we're glad that we now have a person who's dedicated to getting out in the community and working with consumers. So that wraps up my overview of what we have in our toolkit at the state level in terms of oversight activities, and I'll go ahead and hand it off to the next speaker.
Hi, thank you so much. This is Mila Kaufman, and I am with DC HealthLink. We are the District of Columbia's online marketplace for both small businesses and individuals. We are a private-public partnership. We have a private executive board that guides our policy, and we were pretty much built from the ground up. Most policy decisions were based on recommendations of diverse stakeholders and working groups with diverse stakeholders, including consumer and patient advocates, health plans, physicians, and many others. We were the last state to start building the IT system. However, we were one of 4 states that opened for business on time, October 1, 2013, and stayed open. We were also designated as the source of coverage for Congress, and the President of the United States enrolled in DC HealthLink as well. We view ourselves as advocates for our customers. We advocate for the lowest possible premium rates, the best products, and real choices. Next slide, please. This year we offer 136 different products to small businesses and their employees, and we have 26 different products for individuals and families, and that includes 2 catastrophic plans. And I'll just say this, the ACA is truly working in the District of Columbia. Our uninsured rate dropped by 20% according to the latest census data. Next slide, please. So the lesson on non-discrimination from the ground is complicated. We discovered that we had a problem with one of our carriers on the individual side, and the problem was that HIV/AIDS medication was classified on the highest cost-sharing tier for that carrier, and we did not know that. We did not have any consumer complaints. Both the review by the insurance regulators as well as my team, we both missed it. And we learned about the problem through external analysis that was done. And of course, we took very quick action to address it. Interestingly, the carrier also missed it. On their group side, they did not have the same problem as on the individual side. This problem Wayne discussed earlier in terms of his analysis of the Florida plans. So next slide, please. So what we're doing now is we have an additional focus on HIV/AIDS medication in the way we review benefits and formularies. Both the insurance regulator and my staff, we scrutinize those benefits in a more intense way. In addition, we have standard design and non-standard design products. The non-standard products we do not allow benefit substitutions for essential health benefits, and we think that helps address the non-discrimination issues. On the standard products, all of our silver plans essentially now have only copayments for HIV/AIDS medication, so no more coinsurance, just copays. In addition, we, on a regular basis, look at new products that our carriers are offering. So when one carrier offers copays in all of their silver plans and no more coinsurance, my staff essentially require the other carrier to compete on that basis and also offer copays as opposed to coinsurance. In HIV area, some of the medication is very, very expensive. We're talking about over $1,000 per pill. So when you have copay versus coinsurance, that's the difference between making something affordable and not affordable. So that was a very important protection. Next slide, please. Some of the lessons that we've learned, it is very helpful to us to have external experts analyze our formularies and product designs. We do not have the kind of expertise that everyone really should have internally when looking at benefit designs and formularies. This is really an opportunity, I believe, for providers and advocates to help inform not only state-based marketplaces but also insurance regulators on potential discrimination areas. And I'm especially thinking about populations that have been shut out of the private health insurance market traditionally prior to the Affordable Care Act when underwriting was allowed. It would be very helpful to have external experts analyze formularies and product designs so we can make sure that we're doing everything we can to address any potential problems. Societal tools are the right step, but really more is needed. We are in the process of developing a pharmacy tool for our customers. We're working with the Washington Consumer Checkbook, and we're hoping once we launch that for the next open enrollment, both advocates and our customers will be able to be better informed about how different plans cover the prescription drugs they use, but also will help the research community to help us to identify any patterns of discrimination, especially in the formularies. And with that, I'll conclude my remarks.
Mila, let me just ask, we did have a question, a clarification question. Could you clarify your statement that you're not allowing benefit substitution?
Correct. So in the essential health benefits benchmark, for example, in certain benefits, you can have like 10 physical therapy benefits in one product, and in states that allow substitution, you can have 5 physical therapy, 5 occupational therapy, so it's still 10, but it's slightly a different benefit. In our case, through a policy work group early on, we decided that there wasn't going to be any of that type of benefit substitution.
Great, thank you. We have other questions, but let's keep moving on and we'll come back to them after the next set of questions. Sort of asking the states to tell us what's on the horizon for your work. What are you seeing as emerging issues and concerns?
And this is Johanna in Pennsylvania again. So to answer that question briefly from our perspective, some of our areas of interest include formulary design, as we've heard discussed a lot on this call. That is, I think, a broad area of interest. And I would definitely agree with what Mila just said in terms of this being an opportunity for providers and advocates to inform our reviews. Unfortunately, we don't really have that pharmacy expertise in-house, so I think we would be very interested in getting input from external experts on what we should be looking for and considering. We're also very interested in mental health and substance use disorder parity, MAPIA. That's an issue that we've gotten a lot of inquiries regarding in the state from advocates and providers. And with the opioid epidemic around the country, the substance use disorder treatment is something that's at the forefront of a lot of people's minds. Of course, the difficulty there is particularly with the non-quantitative treatment limitations and how to collect information on those and review them on the front end and then also during market conduct exams. So that's something that we're thinking about now a lot. Additionally, we're taking on, as I mentioned previously, plan management functions for the FFM for the first time this year. So that means we'll be really diving into those QHP templates, running the tools, including the non-discrimination tools ourselves, and getting our own kind of first-hand look at the results there, which I think is going to be helpful, even though I know that doesn't capture the whole kind of universe of potential discriminatory attributes. And I'm also excited that we're kicking off market conduct exams this year. We haven't yet kicked them off, but we're planning to roll them out this year on our health insurance issuers, and those will be focusing on ACA issues, including non-discrimination. And with that, I can hand it back to Mila.
Thank you. So I'll focus on some of the things we've been thinking about around 1557. We have taken a number of steps in the area of gender. We're actually trying to eliminate the gender question from our online application. We think that will help prevent some of the barriers to accessing care that certain customers of ours may experience. Transgender and gender identity has been something that the District of Columbia has been a leader in protecting civil rights. We worked very closely with the insurance regulators here. They issued 2 bulletins. The first one prohibited exclusionary clauses as they apply to transgender issues. And most recently, there were also problems accessing certain benefits like gender reassignment surgery. So the bulletins clarified that that kind of activity is considered to be discriminatory and prohibited. So we strongly support the HHS proposed regulation around that and hope to see that kind of strong language protecting civil rights everywhere in the final regulation. The other 2 areas briefly is also in the HHS proposed regulation. One is the new notice requirements. We are very concerned with all of the various notice requirements under the ACA. I can tell you one of our notices currently is 16 pages long. And we know from the research out there and certainly focus group testing that the longer a notice is, the less likely consumers will read it and understand it. So making long notices even longer is not the way to help ensure that people understand what their rights are and are able to utilize their rights. So in our comments to HHS, we suggested that there's some focus group testing be done and a model notice be issued that's actually understood by consumers that state-based marketplaces can then use. The other area of potential concern is around age rating. As you know, the Affordable Care Act allows a 3-to-1 age variation, and we were seeking clarity around what kind of models out there would be considered discriminatory under the new standards. So we're hoping to get some clarification around that.
Great. Mila, there's another question that's just come in for you. If a person of a certain declared gender was getting treatment specific to another gender, does that raise concerns and red flags?
So under our laws, if a person said that they were a female and, for instance, getting treatment that a male would, and if they were denied that treatment, we would be concerned.
Okay, thank you. And again, the PowerPoint will be on our website in a couple of days. Let me stick with Mila. There are several follow-ups, so before we move on, Could you say, let me ask you two at once, Mila. Could you say a little bit more about the rationale for no co-insurance for HIV/AIDS? And could you explain a bit more the type of expertise, the type of analysis that's most useful when analyzing a formulary's design?
Yes, thank you for both of those. So HIV/AIDS medication is very expensive. Some pills cost more than $1,000 per pill. So when you have co-insurance, even if it's 20%, it sounds low enough, but when you look at how much HIV/AIDS medicine actually costs, that co-insurance of 20% becomes prohibitive in terms of affordability. And so co-payments are a much more affordable way to access the higher cost medication. So having the co-payments as opposed to co-insurance in our standard silver plans was very important to us. And then the second question is the type of analysis that would be helpful in looking at the formularies. First of all of our formularies are on our website, dchealthlink.com, and you can go to each health plan essentially and pull the formulary. Our pharmacy tool will be available later this year, so all you'll have to do is plug in the medication and then it will show you how each formulary covers it. We're not there yet. So now it's essentially looking at each formulary. If you represent a community that either has chronic medication needs or catastrophic where the medication is super expensive, it would be really helpful for you to take a look at our formularies and let us know if you think there may be potential discrimination in how certain medication is classified and tiered. That kind of external independent analysis from experts in the field will greatly help us understand whether there is discrimination in the formularies.
Great, thank you. And for anybody, there's been a question about whether these protections are extended to those with chronic disease, such as those with MS. And I think, Wayne, you addressed that.
Yes, in our view, under Section 1557, the definition of disability is very broad to describe someone with an impairment that affects a bodily function as well as a major life activity. And so, in our view, that MS would certainly be covered under that. However, in a complaint, it would require a showing that in the complaint that the person met the definition of disability, and here's why. In the case of HIV, there's a long-standing court precedent that people with HIV who are even asymptomatic meet the definition of disability.
And Wayne, this is Tammy. I think that you also noted with EHBs and outliers that there was some helpful language in the letter to issuers in the preamble, and I thought that MS, and correct me if I'm wrong, I thought MS might have been one of the conditions that they were also looking at with respect to like formulary outliers.
That's correct. MS made it to the list of one of the conditions that Society was going to be reviewing, and I believe it's regarding the formulary outliers. It's my understanding, talking with some of the advocates in MS, that one of the challenges when you're looking at some conditions is that there may not be standard treatment guidelines or protocols. With MS, for example, it's very condition specific and person specific, and so with other kinds of conditions, there are NIH or other treatment guidelines that have been promulgated. But we're certainly glad to see that list get larger from Society's review point, and certainly encourage advocates to conduct their own plan analysis. Again, using the complaint process to bring these issues to light.
What about, following up on a formulary question, what about chemotherapy and very high-cost generic oral chemo agents? Could there be issues that would trigger anti-discrimination provisions here?
So this is Wayne. Just to take that, certainly have been talking with cancer advocates in the cancer community about this very issue. keep in mind that one of the challenges we have is the so-called specialty drugs. That there's in Medicare there's a definition for what a specialty drug is, but outside of Medicare, a specialty drug can be anything that a plan calls a specialty drug, and so that's what makes it challenging, is the lack of a standardized definition. But I think this also goes to the issue of an outlier analysis. So when you have a very expensive treatment regimen, it makes it more difficult to compare plans and find so-called good plans and bad plans. For this reason, it's that second level of analysis, looking at how does the benefit design match up with the treatment guidelines, would be an analytical framework to go after high-cost cancer and chemotherapy treatments.
Thanks. There are a couple of questions about gender reassignment surgery. Would gender reassignment surgery exclusions be permissible under federal law?
This is Tammy. Go ahead, Mila.
Sorry, this is Mila. I can tell you our position is it's prohibited under district civil rights law and insurance protections. You cannot exclude gender reassignment surgery in the products you sell in the district. That would be illegal if you exclude that benefit.
Anyone else want to weigh in on this?
Yeah. This is Tammy. I only wanted to say, with respect to federal law, that we may have different standards under the proposed 1557 for benefits that are self-funded that don't receive federal financial assistance than we do for example, insurance plans which do receive federal financial assistance, so they're covered entities. So if the proposed rule is finalized the way OCR has proposed it, they've said that an exclusion for all transgender services would be considered discriminatory. So that would be prohibited. You couldn't do that, and that would be a federal law. But 1557 doesn't necessarily apply to every group health plan. For example, it's possible that you're a self-funded group health plan that does not receive federal financial assistance, in which case 1557 wouldn't apply to you. So when we're talking about federal law, we may be talking about how it applies to different entities.
Helpful, thank you. What about and I think this is for DC and Pennsylvania, and given the complexity of this and the multiple regulatory responsibilities at the state and federal level, what can the federal government do to help states and marketplaces ensure that plans are not discriminatory? And do you think you have sufficient regulatory clarity and tools now, or is there more CMS can and should do?
Well, to tackle that from Pennsylvania's perspective, I think the tools that are available in terms of reviewing QHP templates and simply creating the templates themselves so we can intake that information in a standardized format has definitely been helpful. But yes, I think there's certainly more guidance that would be valuable. And I think Lisa and Wayne both kind of referenced that. But I think we would benefit from even more kind of formulary design tools and kind of standards of care that we could reference. And also, as Wayne had pointed out, just because something isn't an outlier doesn't necessarily mean that it's non-discriminatory, and I don't think we have all of the guidance there that we could benefit from.
Yeah, I agree. This is Mila. It would be helpful for the federal government to have more sophisticated templates that states can use. And it would be very helpful if the federal government could specifically look at medical conditions, treatments that have had a history of social stigma attached. The insurance world doesn't operate in a vacuum. Insurance products are influenced by people's ideas, feelings, etc. And so what we're finding is there are certain types of treatments that still have stigma attached to them. Things like treatment for hepatitis C things, certain mental health and substance abuse treatment. So what the federal government has done is a good first step, but they really need to do more, identify segments of our population that have been traditionally discriminated against, and develop tools, templates that states can use to figure out if there is discrimination and how the benefits work, especially for those populations. And that will be a great start.
There's a question, a lengthy question here. With things like value-based insurance design, which is growing in the self-insured market, and is about to begin through a demo at Medicare Advantage markets, come into conflict with anti-discrimination designs? And that's a big question.
Yeah, this is Wayne. That's all. I mean, that is new territory and something that we are certainly paying attention to.
Can you say more about what you're concerned about?
No, that's what I can say.
Anybody else?
Yeah, this is Lisa. I would just echo some of what Wayne said. I think it's an area where it would really depend on the actual design of the benefit, where then you would need to analyze it under all the rules that apply to carriers. So I think it would be one of those that you'd have to look at on a case-by-case depending on how that insurance benefit was set up.
Okay. Anyone else? Tammy, can I ask you, we've been spending a lot of time on the Gobet case and its implications for self-funded plans. Could you speak a little bit more? You said under 1557 that the assumption is that there could be a reach to self-funded plans through third-party administrators. Do you think there's any threat in the Gobet interpretation to that self-funded plans would not be touched?
Yeah, I'm not sure that Gobet is going to sort of have much of an effect on whether or not 1557 can be extended to our self-funded plans, at least the way OCR is interpreting it, for a couple reasons. I think OCR was, when they drafted the rule, they certainly noted in the preamble and then I think in a couple of footnotes perhaps that this would go to the health insurance issuer's behavior, but their behavior with respect to their third-party administrator. So they did not try to extend it directly to these self-funded plans. So I think that's one thing. You could sort of analogize it to your typical preemption of a state law where you would say, is the state trying to regulate a self-funded plan? And it looks like OCR drafted the rule so it wouldn't look like it was reaching there. But maybe more importantly is that in this case, what we have is a federal law which OCR is interpreting to extend to self-funded plans, whereas usually when we're looking at preemption, we're looking at a state law that's trying to apply to an ERISA plan. And ERISA will preempt state laws, certain state laws certainly, as we've learned, but not all, but certainly some of them. But ERISA doesn't have a provision that says it will preempt federal laws. And so that's why I don't know that the latest sort of preemption cases are going to sort of help or hurt depending on whether you want it to extend or not.
Great, thank you. A new question. Do the ACA's non-discrimination provisions impact or prevent carriers' medical management tools for Hep C treatment? For example, we're seeing carriers deny new Hep C drugs to all but individuals at end-stage renal failure. All of the cases filed on this topic rely on state law, of course.
Sorry, this is Tammy, and I interrupted you. I apologize. This is something that we've been watching very closely here at Broome because there have been lots and lots of lawsuits filed about this. And as I understand, they can sort of come in different flavors. I saw one that was based on New York state law, and it really focused on that the members couldn't tell before enrollment that, for example, Harvoni wouldn't be covered until, maybe Medivir 3 or 4, right? So when we're getting close to your point of end-stage renal disease, that when they were enrolling, all they could tell was that Harvoni or whatever drug they may have been interested in was part of the formulary, but they didn't see the limitation on how badly their Hep C would have had to progress in order to get there. So that's one way I think that folks are looking at that, and that would go, you could argue that as discrimination, but you could also argue that that's just, poor disclosure and misleading marketing. But certainly I've seen and I've folks on the call are probably familiar with this case as well, where a class brought a case against the manufacturer of Harvoni and Sovaldi, and argued that the pricing of those drugs, because they are very expensive as well, that the pricing was discriminatory, and it was discriminatory on the basis of race, I think because maybe people of particular races may be disproportionately impacted by Hep C, if I'm recalling correctly. So they also raised, sort of this idea that their pricing even of the drug was discriminatory. So I think, my personal opinion, and I'll open it up to the floor, but my personal opinion is that we haven't seen the last of these lawsuits, and that I do think that there could be discrimination claims under 1557, under the EHB requirements, maybe under some state laws. That would get to the coverage of Hep C when it's covered, and sort of cost sharing.
Mm-hmm. Mm-hmm. Anybody else on this question? And others, please add to the chat if you have other questions. We have a little bit more time to address them. We know that the rulemaking is in process. We expect final rules sometime spring or summer. What ought our audience to be watching for, concerned about? And David, maybe you're the person to take that.
Yes, this is David. So, I think in terms of the proposed rules for the rules for Section 1557. So, again, I think one thing to be looking for is to see what the sort of guardrails are that the agency puts around sort of defining, in detail sort of what would constitute discrimination. I think it would be, I think folks are really looking for sort of, as we've heard on the call, this is a very complicated subject, determining what discrimination is, identifying it. So I think if hopefully the agency will provide, some, I wouldn't say black and white guidance, but sort of clear guidance around sort of scenarios that would apply. I'll pick up on sort of what Wayne said as well. Whatever that sort of framework is, I think there still will be an opportunity for advocates across various disease groups to look at the rule and think about the needs of their constituency and really sort of understand how they can look at the rule and find sort of be a partner with the agencies to help sort of frame out some of these complicated issues as they continue to arise.
Great. Of all our speakers, are there final points you want to raise as we wait for any other additional questions or any questions of each other?
Well, this is Wayne with NHELP. Just a couple of points. I mean, I know we've been talking a lot about prescription drug formularies, and that continues to be an issue. And it's not just with some of the stigmatized conditions or the high cost conditions. Although we're certainly looking at things like hepatitis C and even hepatitis B treatments. It's also things like asthma formularies that some plans aren't covering. A second area that we're looking at is in providers access to specialists. And so, network adequacy is its own issue. But the Journal of the American Medical Association featured a study for a couple of months ago that showed that some 15% of qualified health plans surveyed did not have a specialist in one of the 10 essential health benefits categories. And so there are other areas where plans can, through their benefit designs, discourage people with significant health needs from enrolling. And so it's not just in the formularies. It's in these other aspects of plan design. Step therapy is another one. We see step therapy try and fail for things like contraception, and for conditions where step therapy just is not appropriate. So certainly working with advocates to formulate additional follow-up complaints as we go forward.
Thanks. Anybody else? We did have a concern raised from a questioner about plans are resistant to publishing their formularies and making them easily accessible to patients and caregivers. Would that trigger anti-discrimination protections?
Well, this is Wayne. So one of the requirements under the Benefit and Payment Parameters Rule for 2017 is greater transparency in the formularies, and so it can still be difficult for a consumer to piece together what the formularies are, what the tiering structure is, what that tiering structure means, and what the copays or other kind of prior authorization requirements may be. But before that rule, plans would just publish their most commonly prescribed drugs rather than the complete formularies. And so transparency is continuing to be a challenge to make it user-friendly. We'd like to see transparency extended not only to formularies but to the various kinds of services that may be provided as well, in addition, of course, to the provider networks.
This is Mila. If I can just add, I think almost all marketplaces, if not all, have formularies for all of the products. In our case, we have them listed, and you can click on each formulary. We also have online the summary of benefits and coverage. And in addition, we're also working with the carriers to actually upload the actual certificate of coverage. So if a person wants to read the 100 pages, the actual insurance certificate, they can. We have several tools that are already available for our customers. One is Plan Match, which helps you figure out which of the 26 different products on the individual side is best for you. You put in your health condition, any particular procedures you may have planned for the following year, and it gives you your total expected out-of-pocket costs, including the premiums, co-pays, co-insurance, deductible, and then estimated use of health services. So we do have that all online for our customers.
Great. Anybody else? Okay. We seem to have run through the questions that we've been given, so I want to take the time on behalf of the National Academy for State Health Policy to thank these great speakers for a truly terrific presentation. As we mentioned at the beginning, the slides and recording of this webinar will be available on the NASHP website in the next couple of days. I very much want to thank Georgetown Health Policy Institute and Pharma for their help in making this webinar possible, and thank all who have joined us. Clearly, this is an issue that we've just touched upon and we'll revisit, I'm sure, particularly when the final rules do come out. So with that, we want to very much thank David, Lisa, Mila, Wayne, Tammy, Johanna for a very, very useful presentation. Thank you all.
Thank you.